we've talked a little bit about the patients with follicular lymphoma, but there are some other trials in the follicular lymphoma space, combination with rituximab. What do you know, some of the results have been, I think, to my mind, a little bit disappointing, just based on the fact that I think that follicular lymphoma should be a highly immunotherapy responsive tumor.
When you think of follicular lymphoma, talking about infiltrate, we alluded to that before. There's a well-characterized infiltrate now that is inflammatory, macrophage-based, pro-tumor, and then more lymphocyte and anti-tumor effects. So there's a balance with different patients with different presentation. But for years, we have known that follicular lymphoma by itself can wax and wane. So there's clearly something that this is the best model for an immunotherapy if you want to do that. And if you look at patients who receive rituximab alone, the first antibody approved, monoclonal antibody in the context of cancer and then lymphoma, anti-CD20 in 1997, the patients that were treated with low tumor burden and actually who respond well, going to CR and get a short consolidation, 50% of these patients actually doing very well 10 years later. So they basically their lymphoma has been cured. And there's data actually from Steve Bernstein's lab that's showing that there's an induction of an anti-idiotypic response in those patients. But when you go back to Ron Levy's lab, it's interesting to think that part of his patients were refractory follicular lymphoma and had really bad disease, and some of them have been in remission after anti-idiotypic vaccine for 20 years. So this is a great model, and I think that, to your point, we're going to build up on rituximab alone, and there's, as you know, there's a combination with an immunomodulator lenalidomide, where the response rate, the CR rate, was very, very impressive on the phase 2 from MD Anderson. So this has led to a large randomized trial with 1,000 patients. And we just enrolled the last patient in our institution about a year ago, and then we're waiting for the results, and then we'll look at the PFS hopefully next year. But this is, it was rituximab and lenalidomide in combination versus R-CHOP or bendamustine rituximab. And I think this could offer an option that might be not chemotherapy based on those patients. That's a good example on how immunotherapy start to get really replacing chemotherapy.
So, Fred, we've just been talking about the use of some of these newer therapies and the timing of it. Andre was talking about idiotype vaccines and follicular lymphoma. What do you think is the best time to use perhaps a checkpoint inhibitor? I realize there's a lot of data we need to learn, a lot of trials that need to be done, but theoretically, should we be using these very early in the course of disease, later? Does it matter?
That's a great question. I don't think we know the answer to that. With the FDA approval of nivolumab for treatment of relapsed Hodgkin's disease after brentuximab therapy or after autologous stem cell transplant, that's where it should be used in the community outside of a clinical trial. So we need to place patients onto clinical trials to answer that question. I would like to see it moved up earlier and earlier when it works. So for Hodgkin's lymphoma, combining it with ABVD, it makes perfect sense because we can cure patients with ABVD and maybe we can cure more.
There is an ongoing study that just started exactly this, ABVD and nivolumab, with a window of opportunity nivolumab, a single agent frontline before the ABVD in advanced stage Hodgkin lymphoma.
Exactly. What about any concerns about toxicities in that setting? Do you think we'll get synergistic toxicities with a chemotherapy?
Well, that's actually in all of these studies, including brentuximab, bleomycin actually had to be dropped because we know there was pneumonitis with brentuximab, and then here this is, we need no pneumonitis in the context of checkpoint inhibition. So obviously this is an issue, but these patients do not receive at the same time bleomycin. Some of these patients have received heavy dose chemotherapy and radiation, mediastinum sometimes, so risk of reactivation, pneumonitis reactivation. We have not seen this that much,
and in fact, these drugs, these PD-1 antibodies, are FDA approved for treatment of lung cancer, and many of these patients have received radiation. So, in the context of a clinical trial, we'll probably be careful with enrolling patients who've had prior radiation, but it may be safe. The jury's out. The other setting we might want to consider using these antibodies is, again, post-autologous hematopoietic stem cell transplant, as we talked about. Autologous transplant is a curative therapy for Hodgkin's lymphoma, relapsed Hodgkin's lymphoma, as well as relapsed diffuse large B-cell lymphoma. And so combining it with that therapy to capitalize on that homeostatic proliferation, that proliferation of antigen-specific T cells, makes a lot of sense. And there's a number of trials, including at our center, to examine that.
I think in the big picture, to add on the timing, in oncology at large, but in focusing more on lymphoma, we going to reduce some chemotherapy in indolent disease very likely. aggressive, they will still need chemotherapy, but I think that using immuno-oncology approach at large will be a great way to consolidate patient up front after induction therapy. And I think some of these aggressive large cell lymphoma, once they respond to chemotherapy but relapse early, and some of these patients would be great to try to explore and to do something different than chemotherapy, because all the transplant up front has not been the answer really. So that could be the CAR T cells in some situation, but that could be also a combination of checkpoint inhibitors.